And welcome to X-Ray Review. In this video, we're going to look at bone tumors. So I've put together the top 25 bone tumors you need to know on X-ray, and we'll go through each one step by step. You'll get about 10 seconds to review each case, followed by a clear explanation. Every bone tumor that could show up on a board exam is included. So whether you're preparing for a career in radiology or you just want to test your diagnostic skills, this video should be really helpful. So this is an enchondroma, one of the most common benign bone tumors you'll see on X-ray. An enchondroma is a cartilage-forming tumor that usually develops inside the medullary cavity of bone and occurs between the ages of 10 and 40. They're most often found in the small bones of the hands and feet, but can also show up in the long bones like the proximal humerus or femur. On X-ray, enchondromas look like a well-defined central lucent lesion with a possible chondroid matrix calcification, and these appear as tiny speckles or rings of calcification, sometimes called a popcorn pattern. And the cortex may be thinned and expanded, but it usually remains intact. Most enchondromas are asymptomatic and discovered incidentally, but they can cause pathologic fractures, especially in the small bones of the hand. Multiple enchondromas could suggest Ollier's disease, and if it's associated with hemangiomas, think Maffucci syndrome. And this aggressive lesion is an osteosarcoma. This most commonly occurs between the age of 10 to 25, although secondary osteosarcomas can arise in the elderly with Paget's or post-radiation. The most common location is going to be in the metaphysis of long bones, like the distal femur, proximal tibia, or humerus. On X-ray, you'll often see this mixed lytic or blastic appearance to the medullary bone, and then you can also observe an aggressive periosteal reaction. Sometimes these will be sunburst or the Codman's triangle. Osteosarcomas are the most common primary malignant bone tumor in youth, so always keep these in mind. So osteolytic metastasis is the spread of a primary tumor to the bone, causing here this destruction and lytic or lucent appearance of the C3 vertebral body. This typically occurs in adults and is due to spread from lung, kidney, breast, or thyroid cancers. This is most commonly seen in the spine or axial skeleton, although the proximal femur and humerus are other common locations. On X-ray, we're looking for compression fractures or multiple variable-sized lytic lesions, often described as moth-eaten or permeative, depending on their aggressiveness. It takes 30 to 50% loss of bone density to see these osteolytic changes on an X-ray, and it's still the most common overall malignant bone lesion to see on X-ray. Alright, and this is a good example of blastic metastasis. And these are areas where cancer spreads to bone and stimulates abnormal bone formation. And instead of seeing these dark holes like you did in lytic lesions, you'll see bright, white, dense bone. This is usually seen in adults and typically caused from the spread of prostate or breast cancer. These lesions typically occur in the spine, pelvis, ribs, or proximal femur or humerus. On X-ray, blastic metastasis appears as focal or patchy areas of increased density. They can be round, nodular, or even diffuse, and sometimes mixed with lytic lesions, especially in things like breast cancer. number one cause for blastic metastasis is prostate cancer, but breast cancer, carcinoid tumors, lymphoma, and bladder cancer can also produce them. And one thing to remember, these lesions show intense uptake on bone scans, which makes nuclear medicine imaging very useful for detection of mets. This is multiple myeloma, the most common primary malignant bone tumor in adults. It's usually seen in adults over the age of 50. The most common location is going to be in the axial skeleton, like the spine, pelvis, or skull. On X-ray, expect multiple well-circumscribed lytic lesions, or punched-out lesions, seen throughout the skull without sclerotic margins. Diffuse osteopenia is usually present as well. Compression fractures of the spine are very common. In almost every case of multiple myeloma I have ever seen in the spine, there are not just one, but often multiple compression fractures. And don't forget, multiple myeloma is the most common primary malignant bone tumor in adults. Diagnosis is going to be confirmed with laboratory analysis, not necessarily X-ray. This is a giant cell tumor, or GCT. It's a benign but locally aggressive bone tumor. It typically affects young adults between 20 and 40 years old. The most common sites are around the knee, like the distal femur or proximal tibia, followed by the distal radius, like this case, or the sacrum. On X-ray, the classic finding is a lytic lesion that's eccentric, expansile, and located in the epiphysis, often extending into the metaphysis. Unlike other tumors, giant cell tumors typically abut the articular surface of the bone near the joint. So, if you see a skeletally mature patient with an epiphyseal, expansile, soap bubbly looking lesion extending to the joint surface, think giant cell tumor. So this is a benign bone-forming tumor called an osteoid osteoma. You can see this area of sclerosis with this central nidus right in the middle, and that represents the lesion. These usually affect adolescents and young adults with a strong male predominance. It is classically located in the diaphysis of long bones, especially the femur and tibia, but it can also occur in the spine, where it can cause painful scoliosis. So on X-ray, we're looking for a small, round, radiolucent central nidus, and it's usually going to be less than 1.5 centimeters, and it's going to be surrounded by dense, reactive cortical sclerosis. Clinically, it presents with night pain relieved by aspirin or other NSAIDs, which is a key diagnostic clue. So if you ever see a teenager with night pain relieved by NSAIDs, a small nidus, reactive sclerosis, think osteoid osteoma. A hemangioma is the most common benign bone tumor of the spine. These are benign vascular lesions. These are usually seen in adults and are often discovered incidentally, since most are asymptomatic. The most common locations are going to be the vertebral bodies in the spine or in the skull. On X-ray, they have a very characteristic appearance. In the spine, look for vertical striations within the vertebral body, sometimes described as a corduroy cloth pattern. This type of appearance of the vertebral body is a classic presentation of a vertebral body hemangioma on X-ray. So in the skull, a hemangioma typically appears as a well-defined lytic or radiolucent lesion with this characteristic honeycomb or sunburst pattern. On axial CT, you may see the classic polka dot sign, which is caused by thickened vertical trabeculi surrounded by fat. So don't forget, most hemangiomas are discovered incidentally. And if you do see a vertebral body with a coarse vertical trabecular pattern or polka dot sign, there's a good chance it's a hemangioma. So this large bony outgrowth represents an osteochondroma, which is the most common benign bone tumor. And this tumor usually starts in adolescence or young adults where the growth center is still open. Its most common location is at the metaphysis of long bones like the distal femur, proximal tibia, or proximal humerus. On X-ray, you'll notice a bony outgrowth with a continuous cortex and medullary canal connected to the parent bone. When it comes to the cartilaginous cap, the MRI is going to be best for evaluating any type of change, which may raise concern for malignant degeneration. And if there are multiple osteochondromas, it may be associated with hereditary multiple exostosis. So don't forget, most common benign tumor of bone, osteochondroma. So a chondrosarcoma is a malignant cartilage-forming tumor. These are most often seen in adults between the ages of 40 and 75. It most often arises in the pelvis, the proximal femur, or the shoulder girdle. On X-ray, it appears as a lytic lesion with this characteristic chondroid matrix calcification described as a rings and arcs appearance. It tends to be expansile with endosseal scalloping and can cause cortical thinning or destruction. Soft tissue extension may be present in aggressive cases like this. So benign osteochondromas and enchondromas, which are very common, can malignantly degenerate very rarely. And when they do, it's likely to be a chondrosarcoma. So if you see an adult with a large destructive lesion with this rings and arcs calcification, think chondrosarcoma. So this is an eosinophilic granuloma, which is related to benign Langerhans cell histiocytosis. These lesions will occur in children and young adults. These are typically seen in the skull, vertebral bodies, or long bones. On X-ray, it typically appears as a lytic destructive lesion without sclerotic margins. In the skull, it produces this classic beveled edge lesion due to the asymmetric destruction of the inner and outer tables. In the spine, it can lead to vertebral plana, which is complete collapse of the vertebral body with preservation of the disc spaces. Although eosinophilic granuloma looks aggressive on X-ray, it usually follows a benign and self-limiting course and has a much better prognosis compared to true malignancies. So fibrous dysplasia is a developmental anomaly where normal bone is replaced with fibrous tissue. These lesions are typically found well before the age of 30. So it can affect a single bone or multiple bones, but it prefers the ribs, proximal femur, and craniofacial bones. On X-ray, the classic description is a ground glass matrix with this hazy or homogeneous appearance. Lesions are usually well defined with a narrow zone of transition. Bones can become expanded with cortical thinning, but typically maintain contour without fracture. In the ribs and long bones, fibrous dysplasia can cause deformity, such as this classic shepherd's crook deformity of the femur. Polyostotic cases may be part of McCune-Albright syndrome, which also includes café au lait spots and endocrine abnormalities. So when you see a long bone with an expansile ground glass lesion, fibrous dysplasia should be high on your list. So an aneurysmal bone cyst is a benign blood-filled lesion. These typically affect patients under 20 years old when the bone is still skeletally immature. It frequently occurs in the metaphysis of long bones and in the posterior elements of the spine. On X-ray, it shows as an eccentric lytic expansile lesion with thin blown-out cortex, often described as having a soap bubble appearance. MRI can be confirmatory with this hallmark appearance of the fluid level seen with blood layering. It's important to remember ABCs can arise secondarily from other tumors like giant cell tumor or chondroblastomas. So an osteoblastoma is a rare benign bone-forming tumor that resembles an osteoid osteoma, but is larger and less responsive to NSAIDs. These are usually seen in adolescents and young adults between 10 and 30 years of age. It most commonly affects the posterior elements of the spine, or in the long bones. On X-ray, it appears as a lytic expansile lesion with variable mineralization, often in the posterior elements of the spine. So osteoblastomas can mimic an aneurysmal bone cyst if expansile, and can mimic an osteoid osteoma with less reactive sclerosis. And unlike an osteoid osteoma, the pain is not relieved by NSAIDs. Ewing sarcoma is a highly aggressive, malignant, small, round blue cell tumor. These are most likely seen in children and adolescents when the growth centers are still open. They typically arise in the diaphysis of long bones, or in the pelvis or ribs. On X-ray, it shows a permeative moth-eaten pattern of bone destruction with a wide zone of transition. The hallmark is an aggressive periosteal reaction, classically the onion skin layering. Codman's triangle or sunburst reaction may also occur. Soft tissue mass is common, and the lesion often looks far more aggressive than most benign entities. So think Ewing sarcoma when you see a diaphyseal tumor with an onion skin periosteal reaction in a child. A non-ossifying fibroma is a benign self-limiting fibrous lesion. These are typically seen in children and adolescents and are usually found incidentally. The Classic locations are the metaphysis of long bones, especially in the distal femur and distal tibia. On X-ray, it appears as a well-defined eccentric lytic lesion. It has thin sclerotic margins and a bubbly or multiloculated appearance. Most NOFs resolve spontaneously as the patient matures, so treatment is rarely needed unless the lesion is large enough to risk pathologic fracture. This is a Brown tumor, a reactive lesion caused by bone reabsorption and hyperparathyroidism. These can occur at any age. And the most common location are the mandible, ribs, pelvis, and skull. On X-ray, they appear as well-defined lytic lesions that may be expansile. Other skeletal findings of hyperparathyroidism include subperiosteal bone resorption in the middle phalanges and salt and pepper skull. So if you see multiple lytic bone lesions in the setting of elevated parathormone, that should point to Brown tumors. A simple bone cyst or a unicameral bone cyst is a benign, fluid-filled cavity in bone. These are typically seen in children and adolescents before the age of 20. The most common location by far is the proximal humerus, followed by the femur. On X-ray, it appears as a central, well-marginated, lucent lesion in the metaphysis of long bones. If a fracture is present, look for the fallen fragment sign, where a piece of the cortex sinks to the dependent portion of the cyst. If fracture is present, look for the fallen fragment sign, where a piece of the cortex sinks to the dependent portion of the cyst. So if you're looking at a proximal humerus in a child with a central metaphyseal lucent lesion, fallen fragment sign, think simple bone cyst. A chondroblastoma is a rare benign cartilage tumor. These typically occur in teenagers. It originates in the epiphysis of long bones, usually the distal femur, proximal humerus, or proximal tibia. On X-ray, it appears as a well-defined, lucent epiphyseal lesion with a thin sclerotic rim, sometimes with stippled calcifications. Surrounding bone marrow edema and periosteal reaction may also be seen. So if you see an epiphyseal lucent lesion in a teenager, think chondroblastoma. A chordoma is a malignant tumor arising from notochordal remnants. These usually present between 40 and 70 years of age. And the most common location is often the sacrum or clivus in the skull. On X-ray, it presents as a midline destructive lesion with a soft tissue mass. It tends to grow slowly but is locally aggressive and has a high reoccurrence rate. So an aggressive-looking lesion in an adult in the sacrum, chordoma, should be a top diagnosis. This is an intraosseous lipoma, a benign fat tumor in bone. These are usually incidental findings in adults. The classic location is the calcaneus, although it can also occur in other long bones like the femur. On X-ray, it appears as a well-circumscribed lucent lesion, often with a thin sclerotic border or central calcified nidus, which is the fat necrosis. So while these are rare and benign, if you ever see a lucent calcaneal lesion with central mineralization, it's very suggestive of an intraosseous lipoma. So Paget's disease is a chronic disorder of bone remodeling that leads to enlarged, deformed, and weakened bones. This only occurs in the elderly. The classic sites are the pelvis, skull, spine, and long bones. On X-ray, the findings vary by stage. You have the lytic, mixed, and sclerotic phases. But typically how we see it is thickened cortical margins, coarse trabeculi, and expansion of bone. If you compare the left normal side to the right Pagetic side, on the right it's much more thickened cortical margins and coarse trabecular patterns, causing this slight bony expansion which is characteristic of Paget's. So again, we're looking for thickened cortical margins, coarse trabecular markings, and bony expansion. These are the radiographic hallmarks of Paget's disease. So a bone infarct is an area of ischemic necrosis, often related to trauma, steroids, sickle cell disease, or lupus. These are usually found in adults. The most common locations in the metaphysis or diaphysis of long bones. On X-ray, it appears as a serpiginous, densely sclerotic lesion in the medullary cavity, often with a central lucent area. These lesions can mimic enchondromas on X-ray, but in general, a serpiginous sclerotic lesion in the medullary bone, think bone infarct. Plasmacytoma is a solitary form of plasma cell neoplasm, often preceding multiple myeloma. These occur between the ages of 40 and 70. In the most common locations, the spine, pelvis, or long bones. On X-ray, it appears as a well-defined, expansile lytic lesion without sclerosis. Plasmacytoma often progresses to multiple myeloma within a few years, so surveillance is important. So a chondromyxoid fibroma is said to be the rarest benign tumor of cartilage origin. These are going to be seen in teenagers and young adults under the age of 30. It most commonly involves the metaphysis of long bones, often in the femur or tibia. On X-ray, it appears as a well-marginated, lobulated lytic lesion that is often eccentric in the metaphysis of long bones. The lesion has a scalloped contour with thin sclerotic margins and may show cortical expansion. So again, this is a very rare tumor and it can reoccur. Though benign, it can mimic aggressive tumors radiographically, making biopsy important.